We've all done this trick a bunch of times, but now we're going to talk about what is it that you're actually doing? What is the story of taking a blood pressure? All right. You know this part, right? You wrap the cuff around, you got to get the bladder in the right place, so you got to line everything up. You're going to listen over a big artery, right? Because that is where you're going to hear your sounds. Then you're going to use the little bulb and you're going to create pressure around that artery, right? So it's essentially a tourniquet that you can control the pressure of relatively easily. All right. So time is on the x. On the y-axis, we have pressure. Now, what you do first, as you know, you squeeze, 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 make it really tight, right? You have to squeeze it so that the pressure on the wall, in other words, the pressure around the arm, is greater than whatever you think the diastolic or systolic blood pressure is, right? And remember, there's folks walking around with pressures of 220 over 100, walking around, smoking a cigarette in the park, right? So it means if you have to sort of be vigorous at first, okay? So you're going to go way up. Now, what is happening at this point? You've squeezed that arm so that the pressure is so high that the arterial flow cannot get to the hand, right? Remember, pressure is all physics. If I put 200 millimeters of mercury of pressure around the vessel, and there's only 120 millimeters of mercury in the vessel, well, guess what? That vessel is going to be closed. It's going to be squeezed closed by the pressure. All right. So that's what we're seeing here. We have very little blood flow, so we're listening, okay, over the distal part of this artery, but we have essentially created a tourniquet. So when we listen here, of course, we don't hear anything because there's no blood flowing, right? We have stopped the blood. Now we start the, right? So we turn the little thing, air's coming out, pressure on the wall is going down. That means pressure inside the arm is going down. Okay, so we listen over that. Well, at some point, the pressure in our cuff, black line, is going to be just a little below the pressure at the top of systole, right? That at point B, where's point B? At point B here, we're going to start to hear a sound. It's going to sound like a tapping every time that every time the heart beats, it'll be like. What you're hearing is just a little tiny bit of very high pressure blood whooshing past your tourniquet, and you hear that in the vessel, right? So very turbulent flow. It's why the sound at B is sort of ticky and harsh, because you got a lot of turbulence and a lot of pressure. All right, now we continue to let pressure out of the cuff. As we go, each heartbeat, okay, has a little less pressure that it's fighting against at the arm. So first we hear the tap, then we hear kind of a louder whoosh, and then a louder yet whoosh, and then a big loud whoosh, right? Because by the time we get to this beat, well, the pressure is low enough that a whole bunch of blood is now coming past your tourniquet, right? But it still is doing so in a noisy way because it's heavily constricted by the pressure around the outside. All right, so down, down, down we go. Well, what happens at C? Well, at C, our tourniquet now has a pressure that is less than diastolic blood pressure. In other words, at point C, our blood pressure cuff is no longer an impediment to blood flow, okay? So at that point, things are starting to get back to normal. Blood doesn't make a sound. Normally, when you listen to somebody's arm, it doesn't make any sound. It's because you don't have a tourniquet in front of it. So from B to C, we get loud whooshing sounds. And then as we cross C, it gets quiet again, because now we're below the diastolic pressure, and then from there, it's going to be silent. All right, so what do we write down? Our systolic pressure is when we first hear a sound, easy to detect. Human beings are great at detecting a noise after silence. Okay, so we detect systolic blood pressure very easily. Diastolic blood pressure is when we stop hearing a sound. Humans are not as good at that, right? So like being very accurate in when a sound stops is not something our brains are particularly good at, which means that we are better at detecting systolic blood pressure than diastolic. Now, we can still, with enough practice, you can get pretty close, okay? So, do you think a person does this better or a machine does this better? What do you think? Who says machine? Who says person? Yeah, it's person. Person does it better, right? The reason for that is the machine doesn't have a brain. So it is calculating what it hears. It can't make any judgments about it, okay? So we use machines to do this job a lot, but if you are going to make a clinical treatment change based on a blood pressure, a human being should have taken the blood pressure, right? So don't shortchange yourself, just go in and do it, right? One of the things we'll teach you in clinical medicine is if you're gonna write a blood pressure prescription, you should have checked the blood pressure your very own self, right? Because it's kind of a big deal that you're putting this patient on a potentially lifelong medicine. Be sure that the machine or your other staff members have gotten it right before you go down that path. All right, so A, we hear nothing. B, systolic blood pressure, first sound. C, last sound, diastolic blood pressure. And then D, we hear nothing again because we've taken away the impediment to flow. We can get this right about within 10%. That's pretty darn good considering the rudimentary level of technology that's needed for this, okay?